All right, everybody, welcome back to another episode of the Vitality Code podcast. As you notice, our intro was not done by my esteemed older brother, Dr. Jason Farah. Nick, I know you're abreast of the information, but Jason has had some dental mishaps and ended up with a bit of a Mike Tyson-esque looking face. Not Mike Tyson as they looked like him, but went 2 rounds with Mike Tyson, I think. So Jason had some procedures done, ended up getting a bit of an infection in his face, and so we thought better than to scare the crowd and maybe diminish his good looks. We have a guest today, so I'll be flying solo without my partner, but we have a guest, and we're going to talk about chiropractic concepts, musculoskeletal concepts today. This is episode 21, Nick. So we've been cruising along pretty good. It's exciting. It's good to start getting some guests. I think that's important to give different perspectives. It also starts to touch on some of the other avenues of my practice personally. I started out as a chiropractor in 2007. And then here we are, fast forward 2024 now, and I do nurse practitioner work, testosterone replacement, and that has started to take over the majority of what I do, but I still have origins in chiropractic medicine. During that transition from chiropractic to nurse practitioner, one of the things that we did was we hired another chiropractor. So he's going to be joining us today. His name is Dr. Pirie, Dr. Anthony Pirie. We just call him Dr. Anthony. He is a graduate of New York Chiropractic College, graduated in 2020, practiced through COVID right in the heart of it, right? In New York City, Anthony?
Yeah.
That had to be quite an experience, experiencing COVID from essentially, in some respects, ground zero, the complete opposite of what we experienced here in Florida. So that had to be an interesting practice.
Yeah, it was pretty interesting. The first year, I was actually a physical therapy assistant in the nursing home for the first year.
Oh, wow.
And then I transitioned into I got my degree, and then I pushed into the chiropractic side and was in an office in Midtown.
Dang, so you were literally almost ground zero if you think about it from a nursing home perspective, because that was, and this is not a political show, but that literally turned out to be one of the huge mistakes that it seemed that maybe New York made in terms of how they handled COVID as it went through nursing homes. And again, nobody knew, so we can't really play, Monday morning quarterback. But nonetheless, that had to be quite an experience. So you were in the nursing homes. That was in 2020 or 2021?
2020 into 2021, yeah. So April.
Okay, so right in the heart of it. So what was that like? Did you have to scrub in? Did you have to wear full hazmat? Did they put you on a mask? What did they do?
So I worked in the nursing homes. I went and did my residency in Long Island from a sports perspective, but to make money on the side, I continued to use my original license. And getting a job in a nursing home is the easiest thing in the world, especially when COVID hits. So
you mean that we wanted to do that?
It was very interesting. My roommates were definitely like, "Hey, peace out. I'm not going to be with you anymore if you're going to the nursing home."
Oh, really?
Yeah, so they shut everything down. So I had this beautiful little place in Long Island with 3 other guys, and everyone else scurried and went back home. And I just went to the nursing homes and would go home and study stuff, take the boards. But it was pretty interesting. Yeah, you'd have to, we were taking the nasal test twice a week, scrubbing in, full hazmat suit, wearing the mask, wearing the shield and everything. And it was a shit show.
Wow, that's wild. So your roommates just kind of left because of COVID, or because you took a job, or just all of it?
Because of COVID in general.
Right.
School made it so you didn't have to be on campus any longer or at your residency, so you could just kind of go home and do the online work and take the boards.
Yeah. Now, looking back at that, do you think that played any role in your education? Was that it had to be a huge switch? I can't imagine being in my last year getting ready for boards. That's your practical year, and then all of a sudden, boom, bomb drops and the bottom falls out.
Yeah, it was massive. I was lucky. I'm very fortunate that I had 5-7 years of a background of working with patients direct care, because I couldn't imagine if that got taken out from under me. Your one chance, obviously so there's 10 trimesters in chiropractic school. You went through it. The 7th try, you do 1 trimester on campus where you kind of fake with each other and, you guess and go. And then your 8th, 9th, and 10 are done at a different outside location, outpatient essentially.
Right.
So if you were to take away those 3 trimesters and you never
Wow.
had direct care, I couldn't imagine.
That's true. So literally some of your classmates, I mean, I was in a similar boat. I was a massage therapist for quite a few years before chiropractic. And while very different in its application, the interaction with patients, the interaction with clients and being able
Huge.
to speak was very helpful. But so you had literally had some classmates who had never interacted with a live patient
More than
outside of that and then
Yeah, more
graduated without that.
than 50% for sure.
Wow, that's huge. Man, and then you were thrust right into the heart of it. I went to New York City teaching some hormone replacement, and it was 2021. I took my middle daughter with me, and I remember walking down Fifth Avenue. We were arm in arm with our arms spread out like this and
Yeah,
didn't touch a soul. And I was like, she had no concept. This was her first time ever in New York City. I'm like, no, you don't understand. This is unheard of. There were nobody around. Like there was a few stores opened up,
yeah.
but it was wild. So was your practice affected? Were people still coming to you in that? Like what was that?
Yeah, we would probably lose we held around 50 patients per week at both offices, and we probably would lose probably about 4 to 5 people a day from calling in and being sick. Hey, I tested
Mm,
positive, I can't come in. So
man.
it was a different world. The hardest part was honestly when we was that gray area. When COVID hit, everyone stayed inside, and then everyone kind of trickled out. The weather got a little bit nicer, and then we kind of dropped some regulations and stuff like that. That's when the most call-ins actually started happening because people
Wow.
were just testing positive left and right. It was
And it was a debacle. I mean, I always say it doesn't matter what side of the COVID thought process you were on. That was probably one of the most mishandled, absolute failures of regulatory bodies that I've ever seen, and it it was terrible. So I can't imagine being on the heart of it. Here in Florida, we had a little different experience. We closed for 2 weeks and then opened up fully.
yeah,
Our, our,
very different.
I just closed because the world didn't know what was happening. We had no idea. It was going into spring break, so we pretty slow week here in Tallahassee for us. Anyway, so then we closed for the next week. Our big, we never had anybody calling in. I can't even remember staff testing or any of that kind of stuff. But the big thing we had was like, do we wear a mask for this patient? Do we not wear a mask for this patient? Like that was
Yeah,
our big decision making process for that day, and that went away pretty quick. We realized it wasn't going to make a difference, and we realized it was a bit of a, I don't want to say it was a. I'll use my language sparingly here, but it was maybe not quite what we were led to believe, and that became quite evident here in Florida. And so we're happy to see that. But nonetheless, so what I wanted to talk to you, Anthony, about was one of the things I've noticed since I've been practicing chiropractic for a while, since 2007. When you come out of school, you are really up to date, research heavy. You know the research, you know the names of the researchers. You have this theoretical basis for how you're going to treat patients. You have the idea of 37% of this, that, and the other, but you have no practical experience. You have zero, right?
right.
You know this idea, and then when you've been practicing for a while, you become better practically, better practically, better practically, hopefully, better practically, better practically. And I really experienced that. But when we transitioned and hired you, I had and I always knew this, but I had a better understanding of it in a real world sense that maybe my knowledge of the up to date research had started to become outpaced by my practical knowledge. And I think as a good physician, you really have to have both, right? If you are research heavy and practical knowledge weak, then your protocols may be not so good. And if you're
Yeah,
only relying on these really good practical research, and you got to have both of those things. So what I wanted to touch on base with you, I think, is cervical pain. That was one of the ones that I always found difficult. And so I wanted to talk about some cervical pain stats, some ideas. There's some new concepts coming out. There's some old concepts that seem to be re-emerging, such as cervical traction. I want to touch on, if you're comfortable, and see if there's any changes in the research on cervical manipulation and negative outcomes and things like that. And
yeah,
so I wanted to just talk about maybe in the beginning, like I think in the medical practice and the chiropractic practice, we all talk about low back pain. We know the prevalence, right? The stat I was always told and always throw out is 80% of patients across a lifetime will experience some episode of low back pain. But I don't really even know if I could give you a stat for neck pain. My hunch, and you can tell me if I'm wrong, my hunch is it would be less than low back pain, but it'd be higher than what my guess would be. So would you know
Yeah, so
what was
with cervical neck pain in regard to upper back to lower back pain, the biggest difference is actually the reoccurrence rate. So
mm,
75% of all people will experience one episode of cervical neck pain, and 56% overall, which is more low back sits are a little bit around 35 to 45. So we're above that halfway marker. Will continue to have an episode of neck pain for 6 months plus, and then
interesting?
it's gotten even deeper. Over the last decade, the research has shown that 21% of the population is now experiencing more neck pain related injuries. So it's starting to increase at a pretty rapidly pace.
Interesting. So let's talk about that reoccurrence. So let's go back to that stat. So what percentage did you say would experience some level of reoccurrence?
54% overall.
Wow. And that is that a reoccurrence? And you may not know the answer to this, the study may not have actually elucidated this, but is that like resolution of neck pain and then reoccurrence after that, or reoccurrence
So
within the same treatment?
reoccurrence within the same treatments, 6 months
Uh,
plus. And majority of the research still states though. I mean, low back pain and neck pain, they're going to share similar correlations just because end plates, vertebral bodies, disc, right? And one of the biggest things with reoccurrence rates is the fact that the lack of blood flow to that area. And it's one of those things, it's kind of like pulling a scab, right? If I herniate or protrude somewhere in my lower back, and I kind of 6 months later, it's going to occur again, right? Because you're going to constantly move into those positions. And next the same way. And since we've moved into workforce has changed a lot, right? Like we've gone from industrialized society to kind of sitting behind a desk, especially post COVID. So everything since that is, forward head posture. We're putting so much more pressure on the disc nowadays than we did previously.
Yeah, I remember reading in school, which feels like forever ago now, but I remember reading a study where they sort of theorized that as the population became less factory based, less manual labor based, less uh, compromising from a physical exertion standpoint, that spinal pain and work injuries would go down. And the exact opposite has happened, right? I mean, and even in Tallahassee, where we both practice, I tell people, I have ties to my CrossFit gym. We are plugged into the fitness community. You have a background as a power lifter. If I had to make my living from spinal pain off of sports only, it's dwarfed by the amount of office workers that I see. So it's interesting that this almost juxtaposition where if you sit for a long period of time, if you have less movement, then you're going to experience actually more spinal pain than pain coming from movement or exercise. Would you say that's
Yeah,
true?
yeah, 100%. One of the studies that actually surprised me the most was they did a study out, and it's a little bit outdated, I guess, from a research standpoint, but it was in 2008. They went and they did a big case study of above 1,000 people with dental clinicians, and it was the
Mm.
hygienists and the practitioners, etc. And with the dentist, they found 60% of them were going to have chronic neck pain, and the dental hygienist, it was 76% are going to have some form of chronic neck pain, just due to that work position that they're going to be putting themselves into over and over again. So I mean, that's something.
Repetitive, yeah, repetitive positions, stationary positions. That's interesting. So the dental profession, I noticed that, and I've talked to my brother about this. I was lucky enough to go early in my career. There's an orthopedic surgeon here who was kind enough to let me go watch surgery with him, and then a vascular surgeon who let me go watch a thoracic outlet, participate and scrub in on a surgery with him. And my God, I spent hours. I can't remember how many hours it was doing that thoracic outlet surgery, but hours I was looking down in a neck flex posture without moving, more than 2 or 3 feet. And by the end, my traps, my neck, I had a headache, and I was like, Jason, how do you how do you do this day in and day out in a surgery stationary position? Um, so then let me ask you then so how this has been a debate as I remember when I was in school, but you can kind of fill me up to date with where we are now. Like, how important is posture then? Is posture the only thing? The thing? Does it matter at all? Does it not matter at all? Like, where does that play a role?
Yeah, posture is an interesting one, right? Because at the end of the day, It matters only if it matters, right? If I come into an office and I have pain and I think that it's posture driven, which majority of society now thinks that plays a key role in being a pain contributor. So as a patient, if I take myself, or if I change my position out of that posture and it alters my pain, then yeah, your posture is going to play a key role in that pain itself. So that's the biggest thing is if I go in an office and I believe that my pain is postural driven, and I alter that position of the posture, then it's going to play a role in the pain. Now, secondarily, you have to look at scapular positioning, forward head carriage, but it puts you it gives you a treatment plan and a key outline of how you can change those other factors to take away the pain. So yeah,
So,
I'm a big believer that posture plays a key role in pain.
and when we say posture, would I be correct in assuming, for maybe those of us not in the industry, would you be referring to a forward head posture, or would you be referring to multifactorial? Like, what would be a significant postural position that would be a driver of neck pain?
I think posture is going to change for every single person. So I'm going to say posture that is altered by your daily life activities. So natural standing up, I don't think is anything worse than if I military. We always say military neck, right? Like straight posture, shoulders back, versus kind of hanging forward. I don't think those, from a postural standpoint, play a key role. But if I sit in a chair and I put myself into a poor lumbopelvic position, poor scapular position, and a poor neck position due to my ergonomics, those are going to be key factors in pain.
I remember a lot from my early career. I always try to drive home to patients. I would correct a lot of neck posture by correcting low back posture, because in that sitting position, it seemed as if the neck posture was ultimately driven by low back posture as a primary. And what I mean by that is you would lose this lumbar extension, you would start to fall into lumbar flexion, and then what would happen is your neck would shift forward, your traps would round, your shoulders would round forward, and then you had this sort of like hunched over position. But if you simply corrected the low back posture, it seemed to alter that neck position almost naturally.
Yeah, I would agree. I would agree with that. And the hard part is overall, like you can dive as deep as you want into the research, and they kind of all say the same thing: is even with high the prevalence is of neck pain, we still don't really understand the underlying mechanisms behind why it hurts.
Mm.
No matter, like, we've dove into it so deep.
Yeah, and there's not really great indicators of specificity of tissue generated pain and which and how to approach that.
Correct. Correct.
Yeah. So what is, and I'm gonna throw you a leading question because I'm thinking something specific, but I want to see I'll lead you there. What are the current trends in treatment for neck pain? Where is that heading? If we're not 100% sure still, what are the specific tissues that are driving this pain? Where is the treatment modalities at the current space and time?
Yeah, currently the best thing to do for cervical neck pain, you can look at all the research, is traction-based activities.
Right.
So whether it's manual traction or it's using spinal decompression or a traction machine at home, it's a great way to alleviate overall neck pain.
I was,
Secondarily,
yeah, go ahead. Secondarily.
secondarily, it's always important too. Is which diving into the research always surprises me is how important like the biopsychosocial model is. That was one of the key things when I was doing a lot of the research is how heavily it's correlated with anxiety, depression, and sleep issues. If they play key issues with neck pain as well.
Interesting. So, would you expand on that a little more? Meaning that patients with neck pain have anxiety, or people who have anxiety are more likely to have neck pain, or do we even know?
Yeah, you might know a little bit more about this than I do, but it's chronic pain is a very hard thing. We from a pain standpoint, chronic pain is always a really really hard one, right? Someone comes in, they're like, my neck is hurt for the last 5 years, and research is showing that it's starting to show a trend in like the psychological aspect of it from the biopsychosocial model, that typically the patients who are on a higher scale to have some form of chronic pain are the patients who are going to have a little bit more anxiety, a little bit more like insomnia, sleep issues, and just be more mentally fatigued overall. That kind of brain fog mentality.
Yeah, that's interesting. I always used to tell my patients in explaining the difference between low back pain and neck pain is low back pain was one of those things that didn't necessarily scare you, but it was like cumbersome in your life. It tended to be a dull ache that was sometimes really hard to get rid of, but was never alarming to people. But when your neck hurt, it seems to be two things: is it made you a little bit grumpy and angry because it's just affected so much of your life.
Yeah.
Like if your low back hurt, you could stand or you could sit or you just couldn't exercise. But when your neck hurt, you found it hard to sleep. You found it hard to interact in your daily life. You turn your neck and oh, it hurts, and you're mad at that person who called your name as if it was their fault. And so you get this sort of um, start to encroach on those social aspects. I think a little bit more than low back pain. And then I think it also, just due to its proximity to your maybe considered more vital structures, right? Your head, your neck,
Yeah.
headaches. Could this be something more significant? It seemed to anecdotally drive some of those psychosocial things that I think just the nature of the pain itself. And I found this to be true. And I don't know if you have seen this in your practice with your patients, but neck pain out of an acute onset, when it's sharp, you're just scared to do anything because you're not sure, man. Am I going to sneeze and oh god, all hell's going to break loose? I can't turn my back, so I'm doing this, and then you're just afraid to do anything. And so it creates this greater fear cycle, I think, than low back pain, maybe.
Yeah, I would 100% agree.
So it's interesting that you say traction, because that was a big one when I was in practice. And then it kind of went out of favor. And now you're saying that some of the research is going back to pointing at that as a tried and true mechanism of pain
Yeah,
treatment for
so
the neck.
I mean, the beauty of traction is if you look at the cervical spine itself, some of the biggest pain drivers of the spine itself is degenerative changes in the disc. So like, you're getting a little bit more bone on bone, it's pushing onto it. That disc is only made of so much water and type 2 collagen that eventually you get, you hit upper 40s, low 50s, you get some more degenerative changes in those end plates, which are highly, they have a lot of sensory neurons in them. They're highly fiber based. Being able to decompress that area, even if it's for a short period of time, helps alleviate pain. And being able to do it multiple times a week or multiple times a day, even with at home units, it's a great indicator of treating neck pain. And then and Jeff, I mean, how you've been a chiropractor for more than I have. I mean, the case of the radicular pains, numbness down the arm, stuff like that. Like I'm sure you've had to see an increase in that over the time since you've been practicing.
Yeah, that was one of the more scary ones for patients too. Like I would see more patients go to hospitals because their pain would be going down their left arm and they were obviously thinking heart attack or things like that. And so that was one of the big ones. But spinal decompression or traction, and maybe we should take a step back and say, like, what is traction, right? So we're doing a long axis stretch, I guess would be a way to think about it. So if you're a patient, you're maybe laying on your back, and there's a machine or an apparatus that is just adding weight and stretching you in a long axis direction, right? Or if you're sitting, it's sort of
Correct.
pulling your head up to kind of
Yep.
alleviate that pressure, right?
Correct. So traction is essentially a non-invasive approach. You get hooked up to a machine, and it takes a certain percentage of your body weight. That's how they do it. From a standpoint, they look at how much the person weighs, and that's how they calculate how much poundage is actually going to be used to pull on that rope to traction. So essentially, you take one block, and you're blocking the base of the seven cervical vertebrae. Usually, you want to try to isolate the bottom as much as you can, and it's a unit that's going to slowly separate over a period of time. Kind of the most popular type of traction. There's two main big ones that are still practiced: is sustained traction and then intermittent traction. So intermittent traction is the one that you will find most commonly used in a physical therapy office or a chiropractic office. Essentially, the ones that we use here at Pathway Wellness are intermittent traction. And in my opinion, that's the one that should be used more. Sustained traction is awesome, but the problem with it is it's better for straight neurological issues. You got to hold and you got to book out hour-long treatments, and you're just constantly being pulled a little bit harder and harder and harder. And so it's got to be more sustained.
Yeah, I was just sort of struck by your approach to describing it. I would always just tell patients, like, let's just traction you. Like I would just pull on their head, right? Or I would put them on over the door unit, and I'd say just boom, do more weight. And like, oh wait, there's an algorithm I should have been following based on the percentage of their body weight. But what I found with traction, similar to, and I know we're not necessarily talking about McKenzie work, but I noticed with McKenzie work is is the intermittent application of McKenzie seem to be better than the sustained application of McKenzie work for two reasons. Is when you're doing intermittent, let's say as reps, like so you're tractioning and then you're relaxing, tractioning and then
Right.
relaxing, is I always tell patients you get plenty of time and input to find out when the majority of benefit had reached and now you're potentially moving into problematic areas, right? Because sometimes even a good thing can be overused. And there's a beeping there because there's the dump truck for the trash is coming out the side there. But nonetheless, so I think the intermittent, my thoughts on the intermittent is you get some traction, then you get some relaxation, relaxation. And part of that is involving the patient with understanding at what point, like, oh, a little bit better, a little bit better, a little bit better, a little bit better. I didn't like that at minute 22 or minute 17 or whatever. And then they can pause. And I always tell patients it's better to do lots of little sets rather than one big long set. And so, and when you say sustain, do you mean like sustain? You're just holding traction for 5 minutes?
Yeah. They do it for majority of protocols. Like an hour plus.
Wow, just straight pulling.
Just straight pulling.
Yeah, that seems. And the other thing I noticed with that is like you might feel really good in the moment, and then when we let that all off, all those tissues compress, and you're like, oh God, I've overdone it. But you weren't. You didn't get that input at the midpoint, at the 1/4 point, at the 3/4 point to know that was coming. But with the intermittent traction, you got chances to kind of sense that and feel that and understand that.
I don't know about you, but my compliance to a 1 hour time period is gonna be pretty little.
Yeah,
I'm not signing up for that.
Yeah, that's tough to sit in a traction unit for an hour. I mean, that was one of the compliance. You say that like compliance for hyperbaric chamber was we found that to be a little bit tough because you got to do a minimum of an hour, right? You can't just pop in there for 5 minutes, and society is what society is, so people are looking for faster and quicker ways to treat things.